So next our modern topic is vertigo. So vertigo, you all might have heard from the elders and all, right? They are having that vertigo. So we'll see what is vertigo and in which all condition we can see vertigo. So vertigo, it's derived from a Latin word meaning turn or whirl. So the patient will come and tell they are having while getting up and all, they will have like a turn or a whirl like movement. They are feeling like they are going to fall. So that is vertigo. So its medical definition is that of an illusion of movement, usually spinning or turning, but occasionally linear movement or tilt can also seen. So mainly spinning or turning movement, but occasionally linear movement, straight line or tilt can also be seen. And because of one of the main functions of the inner ear is to sense the movement of the head, right? If you learn the anatomy and physiology of ear only, you will understand vertigo. Not only vertigo, any disease, first you know the anatomy and physiology, then only you will understand. So the main function of the inner ear is to sense the movement of the head. Okay. So abnormalities of the inner ear or its connection in the brain can cause a illusion of movement, that is known as vertigo. So any abnormality in the inner ear or any connection in the brain causes an illusion of movement, that is known as vertigo. So that is vertigo. Now you got an idea what is vertigo, right? So it comes in attacks, so it comes in episodes, and the onset is sudden. Suddenly it will happen and patient gets a feeling of rotation of himself or his environment. So the patient will get a feeling of rotation of himself and also his surrounding or also his environment. Sometimes there is a feeling of to and fro or up and down movement. So sometimes the patient will tell there is a to and fro movement, and sometimes he will feel like he is going up and down. So attacks comes in clusters. So it will be like a group with periods of spontaneous remissions lasting for weeks, months, or years. It will start and it will be there for some weeks or some months, and for some years. It will be like that. And usually an attack is accompanied by nausea and vomiting with ataxia and nystagmus. Nystagmus is the movement of the involuntary movement of the eye. So it will come along with the ataxia and nystagmus. And severe attacks may be accompanied by other symptoms of vagal disturbances such as abdominal cramps, diarrhea, cold sweats, pallor, and bradycardia. So if it is a severe attack, then these symptoms can also be seen in that patient. Not only that, spinning movement of the head, they will have abdominal cramps, diarrhea, cold sweats, pallor, and bradycardia also. Usually there is no warning symptom of an oncoming attack. The patient can't tell the vertigo is going to come. Okay, but sometimes the patient may feel a sense of fullness in the ear. The patient will feel something is filling inside the ear. After that, vertigo will come. Change in character of tinnitus. Tinnitus is a ringing sound in the ear. There will be some change or fullness of the ear or a discomfort in the ear, which herald an attack. After that, vertigo will come. Normally, no warning symptoms will be there. But in some patients, it is observed that fullness of ear or tinnitus, the sound may change, or a discomfort in the ear is noticed. So that is vertigo. So it can come in an attack. Suddenly, onset is sudden, and it can happen in a cluster, like for a weeks, months, or years. It can come, and along with the nystagmus, ataxia, and all, it will come. Also, if it is a severe attack, along with this, abdominal cramps, diarrhea, cold sweat, pallor, and bradycardia can also accompanied. And also there is no warning sign for vertigo. The patient won't get an warning sign like it will come suddenly, but some patient will tell that there is a fullness of ear and change in the tinnitus, or there is a discomfort in the ear. And disorders of the vestibular system is causing vertigo. So we have to learn what all disorders are there for a vestibular system. So disorders of vestibular system causes vertigo. So these disorders in the vestibular system is only causing vertigo, and it can be divided into two, peripheral and central. So peripheral vestibular system disorders which involve vestibular end organ and their first order neurons, that is vestibular nerve. So the vestibular end organ and the first order neurons, and that the cause lies in the internal ear or in the eighth nerve, that is peripheral. Okay, peripheral away from the central. So internal, the cause will be internal ear or eighth nerve, and they are responsible for 85% of all cases of the vertigo. And central type which involves central nervous system after the entrance of vestibular nerve in the brain stem. It involved vestibulo-ocular, vestibulospinal and other central nervous system pathways. So peripheral means away from the central nervous system. What all that is the vestibular end organs and the first order neurons, and also the inner ear, and the disease is in the inner ear or the vestibular nerve before entering the central nervous system or the brain stem. And that is the that peripheral cause is the main cause, that is 85% of vertigo is because of that. But central is after it entering the brain stem, that is central nervous system pathways are affected there. So that is the disorders of vestibular system that is causing vertigo, and it can be divided into two, peripheral and central. And this is the table showing vestibular disorders, and the peripheral vestibular disorders and the central vestibular disorders. Peripheral disorders are Meniere's disease, benign paroxysmal positional vertigo, vestibular neuronitis, labyrinthitis, vestibulotoxic drugs, head trauma, perilymph fistula, syphilis, and acoustic neuroma. And central disorders are vestibulo-basilar insufficiency, posterior inferior cerebellar artery syndrome, basilar migraine, cerebellar diseases, multiple sclerosis, tumors of the brainstem, and fourth ventricle, epilepsy, cervical vertigo. So I will give a short note on what these diseases are. I'm just giving the heading and what the diseases is. I'm not going detail to each disease. It will be difficult for you also and for me also to give this much disease detailed cause, etiology, symptoms, and management. So I'm just giving a brief idea about a small idea about the name and what is that disease. So first we will start from peripheral vestibular disorders. Peripheral disorders, vestibular disorders, and that first one is Meniere's disease. It is also known as endolymphatic hydrops. So endolymph and perilymph, you know. So Meniere's disease, it is characterized by vertigo, fluctuating hearing loss. In between, sometimes hearing loss will be there, sometimes it won't be there. Tinnitus, ringing sound in the ear, and sense of pressure in the involved ear. They feel like there is a increased pressure and it will burst now. So Meniere's disease is characterized by vertigo, fluctuating hearing loss, and tinnitus, and sense of all this combined will cause Meniere's disease. Vertigo is of sudden onset and lasts for few minutes to 24 hours or so. And Meniere's disease is also known as endolymphatic hydrops because it is a disorder of the inner ear where the endolymphatic system is distended. So it is the size of the endolymphatic system is increased due to the increased production of endolymph. So that's why it is like fullness, inner pressure will increase. It is characterized by vertigo, sensory neural hearing loss, tinnitus, and oral fullness. That is Meniere's disease. So vertigo is of sudden onset there, and it will last for a few minutes or sometimes for 1 day. And the next disease is benign paroxysmal positional vertigo. So positional vertigo, from the name itself, positional vertigo. So in certain position, the patient will get vertigo. So it is characterized by vertigo when the head is placed in a certain critical position. If the patient will move to some position only, they will get vertigo. There is no hearing loss or other neurological symptoms, and positional testing establishes the diagnosis and helps to differentiate from positional vertigo of the central origin. So central origin also, this positional vertigo is there. So the positional testing only will helps in diagnosis. And disease is caused by the disorder of the posterior semicircular canal, though many patients of history have the history of trauma of the head or any ear infection. So the disease is caused by the disorder of the posterior semicircular canal. So you know the three semicircular canals, right? So in that posterior semicircular canal is affected, and the patient may have a history of a head injury or a ear infection. That is a positional vertigo. That is the second disease. And the third one is vestibular neuronitis. So it is characterized by severe vertigo of sudden onset with no cochlear symptoms. So sudden vertigo will come without any cochlear symptoms. Attacks may last for a few days or 2 or 3 weeks, and it is thought to occur due to virus that attacks vestibular ganglion. So vestibular ganglion is attacked by the virus, that's why this is coming. So that is vestibular neuronitis. Management of acute attack is similar to that on the Meniere's disease, and the disease is usually self-limiting. It will resolve by itself. So that is vestibular neuronitis. So sudden occurrence without any involvement of the internal ear, but there will be viral attack in the vestibular ganglion. That is vestibular neuronitis. Next condition is labyrinthitis. So that is inside the ear only, inner ear. So there are different types of labyrinthitis, and that first one is circumscribed labyrinthitis. It is seen in unsafe type of CSOM, chronic suppurative otitis media, and fistula test is positive. And the next condition is serous labyrinthitis. It is caused by trauma or infection, viral or bacterial infection adjacent to the inner ear but without actual invasion. That is, adjacent place only that infection is there, not in the internal ear, but they will get labyrinthitis. There is severe vertigo in that and sensory neural hearing loss also. A partial or a full recovery of the inner ear function is possible if treated early. So it is treated early means it is easy to come back. The recovery is 100%. So that is serous labyrinthitis. So it is not, the infection is not in the viral or bacterial infection is not in the inner ear but adjacent areas. And the next one is purulent labyrinthitis. It's a complication of CSOM, chronic suppurative otitis media. So purulent labyrinthitis is a complication of CSOM. There is actual bacterial infection of invasion to the inner ear with total loss of cochlear and vestibular function. So cochlea and vestibule is completely affected with the infection invading to the inner ear. Vertigo in this condition is due to acute vestibular failure, and there is severe nausea and vomiting. Nystagmus is seen to the opposite side due to destruction of the affected labyrinth. So nystagmus is the involuntary movement of the eyeball. So it will be towards the opposite direction. So that is the third one, that is purulent labyrinthitis. So labyrinthitis 3 times: circumscribed, serous, and last one is purulent. In serous, the adjacent organs are infected by virus or bacteria, but in purulent, the inner ear, cochlea and vestibule is infected, and there is total failure, and there will be nausea and vomiting along with vertigo. That is labyrinthitis. Next, the fifth condition is vestibulotoxic, ototoxic drug. So ototoxic drugs is that the drugs which is not harmful for the ear. So several drugs cause ototoxicity by damaging the hair cells of the inner ear. You know that the hair cells present inside the inner ear. So it will damage, some drugs will damage that hair cells. Some primarily affect the cochlea while others affect the vestibular labyrinth. So some will affect the cochlea and some will affect the vestibula. And these are the antibiotics. Aminoglycoside antibiotics, particularly streptomycin, gentamicin, kanamycin, have been shown to affect the hair cells of the crista ambularis and to some extent those of the macula. So hair cells are present inside this. So this antibiotic will affect those hair cells, and certain other drugs which cause dizziness or unsteadiness are anti-hypertensive drugs, labyrinthine sedatives, estrogen preparations, diuretics, antimicrobials, and antimalarial drugs that will also cause dizziness. So these are the ototoxic drugs which will cause vertigo, and their mode of action may be different. So next cause is head trauma. The trauma to the head. Head injury may cause concussion of the labyrinth, completely disrupt the bony labyrinth or eighth nerve, or cause a perilimb fistula. So trauma can cause the complete disruption of a bony labyrinth or a eighth nerve, or it can cause a perilimb failure, fistula also. Fistula you all know, right? So there will be external opening and an internal opening. So severe acoustic trauma such as that by the explosion. Explosion may cause disturb the vestibular end organ and result in vertigo. So acoustic trauma means it's a explosion Because of the explosion, there is a disturbance in the vestibular and organ, and that can result in vertigo. That is a type of trauma, right? So head injury can cause this condition, or explosion can also cause vertigo. Next comes perilymph fistula. Perilymph and endolymph, you know. So this is perilymph fistula. In this condition, perilymph leaks into the middle ear through the oval and round window. You know, right? The oval window and the round window. So perilymph leaks into the middle ear through this oval window or round window. It can follow as a complication of stapedectomy or ear surgery when stapes is accidentally dislocated. So the stapes foot plate will go and joined in these windows, right? So it can be because of any complication of stapedectomy, the perilymph fistula can occur, or it can also result from a sudden pressure change in the middle ear. So barotrauma, that is in a aeroplane and all, we'll get a condition called barotrauma, will go blocked ears. Diving or forceful valsalva or raised intracranial pressure like in weightlifting or vigorous coughing and all. Also because of the increase in pressure also, it can result perilymph fistula, and that will lead to vertigo. A perilymph fistula causes intermittent vertigo and fluctuating sensorineural hearing loss, sometimes with tinnitus and a sense of fullness in the ear. So perilymph fistula can cause intermittent vertigo. In between, it will come, go. It is like that. Fluctuating sensorineural hearing loss also fluctuating, and sometimes tinnitus and a sense of fullness in the ear. That is perilymph fistula. And next comes syphilis. Syphilis in the inner ear, both acquired and congenital, causes dizziness in addition to sensorineural hearing loss. So there will be vertigo and also sensorineural hearing loss in syphilis affecting the internal ear. It can be congenital or acquired. Late congenital syphilis, usually manifesting between 8 and 20 years, mimics Meniere's disease with episodes of acute vertigo, sensorineural hearing loss and tinnitus. So that is congenital. Congenital syphilis will appear between 8 and 20 years only. So that is syphilis. So it can be congenital or acquired syphilis. And the next one is acoustic neuroma. Acoustic neuroma is nothing but it is the tumor in the eighth cranial nerve. That is acoustic neuroma. So it has been classified in peripheral vestibular disorders as it arises from cranial nerve 8 within internal acoustic meatus. It causes only unsteadiness or vague sense of motion, and severe episodic vertigo as seen in the end organ disease is usually missing. So unsteadiness or motion sickness will only, severe sensation of the motion will be vague. So other tumors of the temporal bone and destroy the labyrinth directly and cause vertigo. So glomus tumor, carcinoma of the external and middle ear or secondaries, they can destroy the labyrinth directly and cause vertigo. And that is acoustic neuroma. It is the tumor of the 8th cranial nerve that will also cause vertigo. And those were the causes for peripheral vestibular disorders. Now next comes to the central vestibular disorders. So it is in the central nervous system. So it is from the brainstem and above till internal ear and the nerves. It comes in the peripheral vestibular disorders, and from there to the central nervous system, central vestibular disorders. In that, first one is vertebro-basilar insufficiency. So here it is mainly because of the reduced blood supply. So it is a common cause of central vertigo in patients over the age of 50 years. More than 50 years, if the patient is coming with vertigo, then we have to consider this condition. There is transient decrease in cerebral blood flow. There will be a decrease in cerebral blood flow. Common causes atherosclerosis, and ischemia in this patient may also be precipitated by hypotension or neck movements when cervical osteophytes press on the vertebral arteries during rotation and extension of the head. If a patient is having cervical osteophytes, that's a degenerative condition, right? The osteophytes will be formed and that will go and compress the blood vessels. Then what will happen? That vessel supplying which area it is supplying, there the supply of the blood will be less. So it can happen by any movement, rotation or extension of the head can cause that one. Vertigo is abrupt in onset and lasts several minutes and is associated with nausea and vomiting. It will be abrupt in onset, sudden onset, and it will be there for several minutes, and it will associate with nausea and vomiting. And also some other disorders like neurological disorders will also accompany: visual disturbance, drop attacks, diplopia, heminopia, dysphagia, hemiparesis. All these things will accompany because of the ischemia. And some patients only complain of intermittent attacks of dizziness of vertigo on lateral rotation and extension of the head. So some patient only complain of the intermittent. In between, I will get a attack when I am moving to lateral or extension of the head. This is the complaint. So that is the first type in central vestibular disorders, vestibular basilar. Next comes the second one, posterior inferior cerebellar artery syndrome. So here thrombosis of the posterior inferior cerebellar artery cuts off blood supply to the lateral medullary area. So here the blood supply is getting cut. Because of that there will be vertigo. So thrombosis of the posterior inferior cerebellar artery. There is a thrombosis in the posterior cerebellar artery, inferior cerebellar artery, and that cuts the blood supply to the lateral medullary area. There is a violent vertigo with the diplopia, dysphagia, hoarseness of voice, Horner syndrome, sensory loss of ipsilateral side of the face and contralateral side of the body, and ataxia. So there other symptoms will also be severe. So vertigo will be there, and one side, opposite side will be affected, the same side of the face will be affected, and hoarseness of the dysphagia, diplopia, all these things will come. That is posterior inferior cerebellar artery syndrome. And there may be horizontal or rotatory nystagmus to the side of the lesion. Horizontal or a rotational nystagmus. And the third reason is basilar migraine. That basilar migraine. So migraine is a vascular syndrome producing recurrent headaches with a symptom-free intervals. So there will be recurrent headache with a symptom-free intervals, and headache is usually unilateral, one side and of throbbing type. And basilar artery migraine produces occipital headache, backside, visual disturbance, diplopia, and severe vertigo, which is abrupt and may last for 5 to 60 minutes. So there will be basilar artery migraine means occipital headache, backside there will be headache, visual disturbance, diplopia, double vision, severe vertigo, spinning movement which is abrupt and may last for 5 to 60 minutes. And basilar migraine is common in adolescent girls with strong menstrual relationship, and along with the menstruation they will get and also have a strong family history in basilar migraine. So that will also cause vertigo. And next comes the cerebellar disease. Cerebellum may be affected by hemorrhage, in hypertension, infarction, in occlusion of arterial supply, infection, autogenic cerebellar abscess or tumors, glioma, teratoma or hemangioma. So all this cerebellum condition or cerebellar disease will cause vertigo. Acute cerebellar disease may cause severe vertigo, vomiting, and ataxia, simulating an acute peripheral labyrinthine disorders. So acute cerebellar disease will also cause vertigo, vomiting, and ataxia. Tumors are slow growing and produce classical features of cerebellar disease. And that is also a reason. So cerebellar disease, hemorrhage or infarction or infection or tumors can cause vertigo. And multiple sclerosis, it is a demyelinating disease affecting young adults, and vertigo and dizziness are the common complaint in multiple sclerosis. There are other multiple neurological signs and symptoms like blurring or loss of vision, diplopia, dysarthria, paresthesis, and ataxia. Spontaneous nystagmus may be also seen. And associated acquired pendular nystagmus, dissociated nystagmus, and vertical upbeat nystagmus are important feature in diagnosis. So multiple sclerosis is a disease affecting the young adults, and also it is a demyelinating disease. In that disease also there will be vertigo is one of the symptom. and tumors of the brainstem and floor of the fourth ventricle. That will also cause vertigo. Gliomas, astrocytomas may arise from pons and midbrain. Medulloblastoma, epidermomas, epidermoid cyst, or teratomas may arise from the floor of the fourth ventricle. These are the examples of disease. They are mentioning it as a commonly, right? Tumors of brainstem and floor of fourth ventricle. So these are the examples of tumors that will cause vertigo. So these tumors can cause other neurological signs and symptoms. In addition to that, vertigo and dizziness will also be seen. Positional vertigo and nystagmus may also presenting feature in tumors of brainstem and floor of the fourth ventricle. And these are the diagnosis, investigation. CT scan and MRI can give useful diagnosis. And epilepsy, vertigo may occur as an aura in the temporal lobe epilepsy. In the temporal lobe epilepsy, vertigo may occur as an aura. And the history of seizures or unconsciousness follow the aura may help in the diagnosis. And sometimes vertigo is the only symptom of epilepsy that may pose a difficult diagnosis problem. So sometimes it is the only symptom of epilepsy, and it's difficult to diagnose. And EEG may show abnormalities during the attack. So epilepsy, also vertigo will be there. Cervical vertigo may follow injuries of neck 7 to 10 days after the accident. So cervical region, any injury is there, that will cause, the vertigo may form after 7 to 10 days of the attack, and it usually provoke with the movements of the neck to the side of the injury, and it will provoke when we move to that side of the injury. And examination shows tenderness of the neck, spasm of the cervical muscles, and the limitation of the neck movement. So there will be tenderness of the neck and the spasm of the cervical muscle, and limitation of the neck movement is limited. X-ray shows loss of cervical lordosis. That lordosis, the curve is lost in the X-ray. Exact mechanism of cervical vertigo is not known. So it is commonly seen in after a cervical injury, that also after 7 to 10 days only it will happen. And if we turn to the side of the injury, it will provoke. And there will be tenderness on the neck and spasm of the cervical muscles. So that is the cervical vertigo, and that is the last one. And it may be due to the disturbed vertebrobasilar circulation, involvement of sympathetic vertebral plexus, or alteration of tonic neck reflexes. So that is cervical vertigo. So this is the peripheral and central vestibular disorders. Hope you understood what is vertigo and in which all condition vertigo is a symptom, and the treatment for all this vertigo depends on the disease, which disease, in which condition this vertigo is a symptom. According to that, we have to give the treatment. It is different for each condition. Okay, so hope you all understood. Thank you.